Good afternoon. Sorry. Good afternoon, everyone, and welcome to the 32nd annual Labelle Lecture. My name is Alex Cernat, and I'm a PhD student in the Health Policy Program, and I will be your MC for today. So we'll begin by giving honor and thanks to the Haudenosaunee and Anishinaabe nations as the traditional inhabitants of the lands where McMaster stands. We have a debt to those who were here before us, and we recognize that it is our responsibility as guests to respect and honor the intimate relationship Indigenous peoples have to this land. It's wonderful to see a large turnout to this year's lecture, both in person and online. And I hope everyone online is able to hear. We're going to get going with words of welcome from Dr. Michel Grignon, who's a health economist and professor in the Department of Health, Aging, and Society. Dr. Grignon will tell you about the Labelle Lecture series in further detail. He'll then be followed by Dr. Laura Anderson, who will introduce our Labelle Lecturer. She will be followed by the highlight of today, the Labelle Lecture by Dr. Lauren Lapointe Shaw, which will then be followed by a presentation from our discussant, Dr. Emil Bhattacharya. We'll have time for questions after Dr. Bhattacharya's presentation and his questions for Dr. Lapointe Shaw. So without further ado, please give a warm welcome to Dr. Michel Grignon.
Thank you very much. So this is my pleasure to welcome you to the 32nd annual Labelle Lectureship in Health Services and Research. I'm speaking on behalf of Jean-Éric Tarid, the Director of the Center for Health Economics and Policy Analysis. The Labelle Lectureship was named in honor of Roberta Labelle, who died unexpectedly in 1991 at the age of 33. She was an assistant professor in what was called at the time the Department of Epidemiology and Clinical Epidemiology and Biostatistics, sorry about that, and which has another name now that I'm not going to try to say. And she was also a member of the CHEPA, the Center for Health Economics and Policy Analysis. I didn't have the privilege to meet her, but I know her reputation. She was fearless, feisty, and formidable in both intellect and determination. She was a dedicated teacher. She was a person of principle and integrity, and possessor, so I was told, of a delightful but pointed sense of humor. Although still early in her career, at the time of her death, she had an impressive record of achievements as a scholar and as a teacher. The Labelle Lectureship is supported by generous donations, and I'm very pleased to acknowledge and thank the donors who make these annual lectures possible and who allow us to celebrate Roberta's achievements and legacy. The lectureship was established to recognize young investigators whose achievements early in their career have been similarly impressive, who have a penchant for challenging existing concepts through innovative health services research, and who, as rising stars in their field, are poised to achieve a great deal more in the future. Thank you very much.
Thank you. I'd like to now introduce Dr. Laura Anderson, who is an associate professor in public health in the Department of Health Research Methods, Evidence, and Impact.
Thank you. I am delighted to be here today to introduce Dr. Lauren Lapointe Shaw. She is an assistant professor and clinician scientist in the Department of Medicine at the University of Toronto, a staff physician in general internal medicine and geriatrics at the University Health Network, and an adjunct scientist in primary care and health systems research program at ICS. Her research focuses on the quality of in-hospital and outpatient care, and she has received numerous awards for this work, including from the CIHR Institute of Health Services and Policy Research, the Rising Star Award. This was awarded to her for her research published in the BMJ in 2018, which showed that patients who were discharged from hospital during the December holiday period had greater risk of death and readmissions. The Labelle Award Committee was delighted and very impressed with her nomination letter, which described her as an emerging research leader with a unique combination of skills in clinical medicine, health services research, and policy orientation. Her research using systems-generated data to identify potential solutions to address the efficiency issues in Canadian health systems is timely and was deemed to be an important priority for us to hear about today. Consistent with the mandate of the Labelle Award, it is clear that Dr. Lapointe Shaw is a rising star in health services research, and we are delighted to have her here today. Please join me in welcoming her.
I have to find the optimal position here. Thank you so much for those kind words and for this invitation, which really is a tremendous honor. So I'm excited to tell you today about essentially all of healthcare, healthcare to keep people out of hospital. And when I was pressed to choose a topic for the talk today, I sort of came together on something that unified all my different research projects, which really span the whole health system. So this is what it is. I will say that, oh, I need to advance. It's not advancing. Oh, there we go. I don't receive any form of industry support. These are my sources of grants and salary support. And today, sort of by way of my personal journey through different research projects and areas of interest, we'll be talking about how demographic trends have shaped hospital medicine, strategies to keep an increasingly homebound older adult population out of hospital and thriving in the community, and through this explore the close relations between home care, primary care, long-term care, and of course in hospital care. So before everything else, I was a general internist, right? So I did general internal medicine residency. And for those who may not be familiar, general internists in Canada are mostly inpatient physicians. We take care of many older adults with medical conditions, pneumonia, COVID-19, that sort of thing. And like my colleagues, as I went through residency, I was faced with this really rapidly increasing patient volumes. So the pace of work just seemed to be accelerating over time, more and more patients coming through the doors. And this is data taken from Gemini, which is a cohort study, essentially registry of general internal medicine admissions. And at the time, it was just for the Toronto area. And you can see this really rapid rise in patient volumes, while at the same time, we managed to keep length of stay stable. So really illustrating like there's a lot of churn there. And this was sort of explained by some larger phenomena that were happening demographically, which we've really just started to taste the beginning of. So the sort of the gray wave that is coming our way in Ontario, but also broadly in North America. So by 2046, it's expected that the number of people who are age 75 or older is going to more than double from 1.2 million to 2.6 million. So this is just for Ontario. And the number of people over age 90 is going to triple. So definitely an important trend. And along with this, we see that there's rising levels of multimorbidity. So i.e. having many different comorbidities. And this is from work that came out of Walter Wojcic's group. And he's done lots of work related to multimorbidity. And you can see, so the shapes are, what portion of the population by age has how many different comorbid conditions. You can see that overall more and more people in the province are living with lots of different medical conditions. And so certainly there's some rising complexity. And this was behind this phenomenon that we're seeing on the inpatient side. I had this growing interest in trying to improve the health system, and I also really enjoyed research methods. So I decided that I was going to do some graduate studies and a PhD. And at the time, what was really hot was preventing readmission. So I finished residency in 2012, and that's actually the same year. Oh, I need to admit someone. That's the same year that the HRRP, so the Hospital Readmissions Reduction Program, was released or introduced by Centers for Medicare and Medicaid in the United States. And this was very innovative, somewhat untested policy. So a financial incentive really to hospitals to do everything they could to reduce readmissions. because they would feel it in their budgets. So up to 3% of hospitals' total Medicare payments were up for clawback if they didn't perform well in terms of their risk-adjusted readmission rates. So this spurred, of course, rapid innovation and lots of research, and explosion of the field of preventing readmissions. And it crossed the border to Canada. And so there's lots of work being done in that area. And I will sort of summarize sort of some take homes from the field rather than talking about my specific projects. But what became pretty clear through the body of research that was building very quickly was that most readmissions didn't really seem all that avoidable. So we would have liked to think that we could actually control, or as one hospital administrator said once in a meeting, that hospital readmissions are a never event. But in fact, it's really quite far from the truth. It's estimated that around a quarter could be reasonably avoidable. And if you think about avoidable by whom and lens of inpatient medicine, which was my lens at the time, it's going to be like half of that or less, right? So difficult to really make a difference. However, there were several multi-component complex health interventions that did seem to successfully reduce readmissions. And I'll give you sort of the take home about all that body of literature, which is essentially that when you tried to isolate any single component, like say, post-discharge phone call or any sort of one piece, there wasn't really that market effect, or even many of these studies were in fact negative for reducing readmissions. But when you had these highly complex interventions that involved pre-discharge, transitional, meaning bridging the gap between hospital home, and then post-discharge elements involving dedicated personnel, you were able to see a difference. And in fact, the more complex, the more comprehensive the intervention was, the greater the reduction in readmission risk. So in some ways it was like, okay, we can do something that makes a difference, but it was a disappointment to many because really there was no magic bullet. There's no like one pill that could, you could give your patient and they could be less likely to be readmitted. No inexpensive, simple solutions. And in other words, more is more, which I think, was disappointment as far as funders and also hospital administrators. So coming from sort of this body of literature, there's been since that time more studies that focused in, they said, okay, well, if we're going to have this really expensive intervention that involves all these dedicated personnel, then we can't just deploy it indiscriminately to everyone. We have to find the people who are most likely to benefit. We have to find those highest risk people. And so this is when all the risk scores came out, and okay, who are the highest risk people for readmission? Let's deploy the intervention with those folks. And this is just two examples. So the virtual ward was one such intervention. And I know Irfan Dalla, who's a great colleague, he actually is a previous Labelle Lecturer as well. And I think he talked about his virtual ward experience. And I actually had the privilege of attending briefly on the virtual ward. Unfortunately, the outcomes in this study showed no difference between the intervention arm and the control. So that was a disappointment. Similar findings out of a recent study out of Switzerland, complex interventions starting with people who are going home didn't make a difference. And then even for studies that you may have, that are maybe a bit more high profile that you might have heard about, like the Camden's Hotspotters study. So this is focusing on people who are already in the community, but who were very high healthcare users, giving them a lot of wraparound care. Turned out it didn't make a difference in terms of their utilization, and same for the trial of Impact Plus, which was in Ontario, and this work again led through Walter Wojcic's team, didn't seem to make a difference. So that was certainly a disappointment, and it gave many people pause, like why now are we not seeing the benefits that we saw from some of these complex interventions? So there was some nice thought about what the potential explanations might be in the New England Journal article related to the Camden's Hotspotters. And certainly when you focus on a high-risk population, you're always going to deal with some degree of regression to the mean, because you're selecting them because they're high users and they're just going to tend to move towards the mean over time. That should equally affect the control groups as the intervention group in an RCT, but it still means that your event rate is going to end up lower. It affects your power. There's difficulties adhering to the protocol. So this was very true for the Hotspotters study. The intervention involved all these outpatient appointments, And this is a population that was high risk, particularly because of various social factors. And those same things meant that it was hard to actually get to the appointments that were the intervention. So this really is like the root of the issue with a lot of these interventions, is that the actual delivery is complicated by those same factors. Some people said, well, these patients are just too high risk. I would say, rather than too high risk, it's that the risk may not be modifiable. So particularly when you're dealing with patients who are high users because they have difficult to control medical diagnoses, it's very hard to predict how biology is going to react one way or another. So for example, difficult to control heart failure, it's true that, you know, catching things early makes a difference, but there's some element of randomness in the biology of a person that you cannot entirely account for. And so some of that may not entirely be modifiable. So this started me thinking really about how do we find the risk that's modifiable? We have these things that we know we can deploy, like we know about the solutions. It's almost like we have a drug and we need to find the target. What are the problems we can actually help with? So what was apparent to me was that patients who were going home, who were functionally impaired, let's say they have functional decline in hospital, it becomes very hard for them to actually get to their appointments. And that led me to start thinking more and more about how do people get the care they need if they're really limited in terms of their mobility. And so this led me sort of to pivot now to thinking about functionally impaired older adults, population that is also rapidly increasing. So this is data from the national, a lot of my images are, they have great figures in these National Institute on Aging reports. And so this is the population pyramid in terms by level of disability severity for semi-current values, and then in 2050. And you can see that we're not just shifting to an older population, but we're also shifting to a more disabled population. Meanwhile, we've got this home care system that's really stuck on 21 hours per week as a maximum, which is like 3 hours per day. But people are more and more functionally impaired. So the MAPLE score is a scoring system that's used to prioritize people for how urgently they need to get a long-term care bed. So like a residential long-term care bed. And you could see the rising proportion that is MAPLE 4-5, i.e. the highest level of urgency. Meanwhile, the long-term care beds just have stayed flat, or at least flat until recently. And so it's no wonder, you know, 21 hours a week isn't going to meet their needs. And it's going to be many times easier to just call 911 and come to an emergency department than to get the care that they're needing. So I started thinking more about like homebound older adults. And there had been a lot of work out of the United States, particularly from Catherine Ornstein. And there hadn't really been much on any Canadian population in terms of describing how frequently this status of being homebound occurs. So what does it mean to be homebound? It means the research definition is something like you leave the home once per week or less, but you can imagine, of course, it's on a spectrum, and it sort of speaks to that withdrawing from the external world. And it relates to environmental, physical, psychological, cognitive, economic, or social reasons. By far, the most common reason is really that those mobility challenges, but they interact with all these other factors, including things like the specific setup of your home environment and whether there's steps to get into your house, et cetera. So being homebound is in itself an outcome because it's like a social withdrawal, but it's also a risk factor for a lot of other negative outcomes. And it's associated with advanced age, having more comorbidities, higher levels of functional impairment, cognitive decline, high rates of depression and anxiety. And homebound folks have more emergency department visits and hospitalizations and high mortality. Now, from my experience when I worked briefly on the virtual ward, I could really feel the issues facing homebound people in terms of getting access to care. So if you are relatively mobile, you could organize, you know, a wheel trans to get to an appointment. Like, let's say you actually need to get testing done. You could sort of cobble something together. But if you're really limited and you're essentially bedbound, the only option to get to a CT scan is an ambulance. And I learned that you can't get an ambulance to go to a clinic or a CT scan appointment. You need to go to the emerge. So this is sort of how we end up in this situation. And when they end up in the emerge, they face numerous hazards of hospitalization, which have been well described for older adults in general, which consists of further functional decline, falls, delirium, which is incredibly common. I would say this is like the #1 thing that my patients will, who if they're older, and especially if they have background cognitive impairment, they will be at high risk of becoming delirious, so acutely confused, which itself has an increased risk of mortality. They often don't eat well, incontinence, pressure sores, various forms of infection. So if we can keep these folks out of hospital, then it's much better for them. And this is actually data from a study in Australia, which looked at patients over age 65. And there seemed to be a dose response effect related to how many of these hazards you accumulated and your risk of actually being discharged to an institution rather than home. So certainly if we can keep older adults out of hospital, I think this is not controversial, everyone agrees, it's better for them, but how do we do it? So this is a infographic from a study that I led looking at quantifying the homebound population, which hadn't been done for Ontario. So we have long-term home care, and long-term home care patients tend to have these RAI assessments, which some people may be familiar with. And it turned out there was a question on the RAI assessment that asked people about or how often they typically exit the home. So we were able to use that to identify what proportion of these long-term home care clients are actually homebound or mostly homebound. And you can see that the proportion was really rising over time, from 48% to 65% of long-term home care clients from 2006 to 2017. Not a total surprise that it's rising, given what we said about the rising levels of disability, the fact that the long-term care beds are static over time. It's the factors that were associated with being homebound were older age, female sex, being dependent on others for getting around, using an assistive device like a walker. It's not surprising. Again, it relates, #1 association is really with mobility, and then difficulty actually accessing the home. So this is the thing like, having those steps up to your door. And so this interaction between the person's risk factors and then the environment is very important. So acknowledging that we have this growing homebound population, and I say homebound, but it's really like a little bit the tip of the iceberg of the sort of increasingly functionally impaired aging population. Some may not be homebound, but they could become homebound if they sort of their functioning decline further. What is needed to keep this increasingly homebound population out of hospital and thriving in the community? So I'm not going to claim that this slide is sort of comprehensive of all possible solutions, but these are some of the things that I think are going to make a difference. And some of these things I have done my own research in. Some I'm just going to share other people's work. I won't touch on mobility interventions, although incredibly important, but that's just here because it's important, but I won't talk about it in depth. So the first thing is, how do these people actually get to see a physician? Because there's difficulty exiting the home and getting to an office appointment. And physician home visits are incredibly important for homebound older adults. And there's been lots of literature about this. And whereas in Europe, it's common practice for family physicians to provide home visits, that's not really been the case in North America. Recently, Medicare, because of sort of value-based care and these Medicare plus or Advantage, Medicare Advantage plus special funding envelopes, there's been a return and a resurgence of physician home visits. And that hasn't really so much been the case in Canada. In terms of the policy landscape for funding of home visits, physician home visits, pre-2005, sometime before then, there was the introduction of these special visit premiums that pay physicians extra for a visit that occurs in a home setting. And then in 2005, there was an additional premium added that was more for palliative home visits. And there's a lot of understanding that, many people end of life, they want to stay in their homes. They don't want to be institutionalized. And so we need to attract physicians to the field of providing palliative home visits. In 2012, there was the addition of volume-based incentives for providing non-palliative, so meaning like all the other types of home visits. And this is our own data from home visits in Ontario, and I hope it's visible, but essentially, so starting in 2005, you can see sort of steady climb in the green line, which is the palliative home visits. 2012 is when those volume incentives were introduced, and there's an inflection point in the visits provided to home care recipients, and that's sort of, we use that as a proxy. We know that it's an imperfect proxy, but use it as a proxy for people who have some degree of functional impairment, because it was home care for PSW, so personal support worker. So these people usually tend to have functional impairment. And then other is sort of the ones that aren't either palliative or home care recipients. So we could see post 2012, there was really an increase in other and also visits to home care recipients. Just for overall context, the volume of home visits is incredibly low. So like these lines are at a level that is 100 times, it would be 100 times higher if you were looking at office-based visits. This is a tiny proportion of overall primary care in the province. And so a shout out to my colleague, Aaron Jones here, because this is actually his work. There's evidence even for Ontario that if your regular physician provides more home visits, then you're actually at lower risk of going to the emergency department. So this is, again, this is observational, but what Aaron did, and I was happy to be part of this team, was divide the physicians into quartiles according to the volume of home visits that they provided, and then looked at their patients' use of the emergency department. So this was actually, this is a pattern that is consistent with our understanding of what home visits do to help older people with functional impairments. So I should have said that up front. This is an older population with functional impairments that was also long-term home care recipients. So then what we did is we wanted to know a little bit more about all home visits. So we knew there was already research quite a bit about palliative home visits. We knew this stuff that I just mentioned about, you know, if your doc provides lots of home visits and you are a person who is older and disabled, but how are home visits being used in general throughout the province? So it was quite an eye-opening experience. It turned out that more than half of the physician home visits in Ontario were going to patients who were neither palliative nor receiving home care, which we use as a proxy as functional impairment. So like, who are these people who are neither palliative nor receiving home care but are getting home visits? Many of them were children, 21% were under age 18, and within this pediatric group, a third had a diagnosis of acute nasopharyngitis, i.e. a cold. So a non-significant portion of these home visits, which cost more, were being used for children with colds. And overall, this group of recipients of home visits who were neither palliative nor home care patients were younger, had fewer comorbidities, and of course, used less hospital-based health services as well. When we looked at the physicians who provide home visits, also quite eye-opening, the top 5% of physicians by volume of home visits were providing 60% of all the home visits in Ontario. So there was a lot of physicians, typically family doctors working in these patient enrollment capitation models, who did low amount, like low volume home visits, sort of, you know, you imagine like end of the day, see your patients for homebound kind of thing. And then this group that was like very high volume. They tended to see mostly patients who were not enrolled to them, meaning they were either didn't have enrollment to any physician, so enrollment in the patient enrollment models, or enrolled to someone else, and they practice mostly in large urban areas. So this kind of raised some suspicion that maybe some of what we were seeing was some commercial physician home visit providers. So you may have heard of some of these groups like MedVisit, MD Home Call, Free with OHIP 7 days a week. So service providers that are really in the business of providing high volumes of home visits. So this is a model that I created just in this talk. And of course, you know, a room full of economists, no doubt this is an oversimplification. But increased pay, you know, that was meant to compensate for the added travel time or the increased complexity seeing these patients led to kind of a profit opportunity. And then you have attracted sort of players who are in it for kind of profit reasons. And then you can see some decreased complexity of the patients in terms of building up business, attracting, you know, children, advertising to parents, decreased comprehensiveness of care. So a bit of a situation where what we originally intended with this increased funding is not at all related to what has happened in the end. So a shout out to the movie Inside Out. If you haven't seen it, it's very funny. And this is when joy and sadness, it's a movie about emotions, joy and sadness get stuck in the abstract thinking part of this girl's brain and they get deconstructed. So that is essentially what has happened. It's an analogy for home visits when, the idea of home visits delivered a certain way was great, but then what happened on the ground was something else. And this talk wouldn't be complete without a shout out to Roberta Labelle's paper talking about supplier-induced demand, which is very relevant when we think about these services that are sort of on demand. Physician, you could call anytime and get service. And she broke up the different types of supplier-induced demand in healthcare into quadrants according to the effectiveness of the services. So did the service contribute positively to the patient's health status? And then the effectiveness of patient agency. So if the patient knew everything the doctor knew, would they still want this? And I think we could probably agree that for physician home visits, we're operating in quadrant 1. Sure, it's unlikely to be harmful, potentially helpful, patients want it. But as she said, and this is a quote from the paper, utilization in cell 1 is the most complex set. The problem is that even effective services may not be cost effective, and even cost effective services may not be worth their opportunity costs from a social perspective. So I think very wise words that are quite relevant here. And so the update on the saga of home visit funding for physicians is that in 2019, right before the pandemic started, the ministry changed the premiums such that now you could only really get physician home visits if you were palliative or if you're a frail, homebound older person. Now, we don't know yet in practice if this has really happened because then the pandemic happened, home visits went basically to 0, so the data is kind of all over the place, and I haven't gone back to it, but this remains to be seen what happened since then. So that's physician home visits in Ontario. So the next thing that I think, can be helpful with this older population that is sometimes has some difficulty accessing care is virtual visits, which of course we've all become, I think, more familiar with since COVID-19. There's many theoretical advantages in terms of patients being able to talk to a physician in their home. They save on travel time, they save on parking money, increased accessibility, particularly for those who are in rural areas where there may not even be a primary care provider for miles in any direction. However, there's also barriers that have been described in terms of having access to the technology needed, particularly for video calls, and then the knowledge to kind of work that technology. Interestingly, in Ontario, we kind of use the term virtual to encapsulate both video and just phone calls with your physician, which I think there's some debate, especially outside of Canada, is a phone visit really virtual? But in any case, certainly the advantage of phone is that most people are able to access the phone, but then you don't have that visual assessment of the patient. So when COVID-19 struck, explosion of virtual care because there was a shortage of personal protective equipment, and also people didn't want to have that face-to-face, that risk of infection. And soon started hearing from, as the pandemic wore on, from emergency department colleagues saying, we're seeing all these people who can't get in to be seen in person because their family docs are only doing virtual. So then, because of people saying that, Tara Kieran led this study, which looked at essentially if your regular family physician is a high user of virtual care, are you more or less likely to actually go to the emergency department? And it turned out that you were less likely. So those high using family docs who really embraced virtual care, their patients actually, they had a lower rate of emergency department use. So this contradicted this mythology that was developing in hospitals around these family doctors abandoning their patients. So it wasn't the case. Now, in contrast to this study, which was really focused on the virtual care practices of your regular physician, so in most cases, that's like your enrolling physician, I was interested in virtual walk-in clinics. So of course, you've heard these names, Maple, Babylon, Rocket Doctor. There was an explosion of these corporate entities also during COVID-19. And we were able to use health admin data and find encounters for 13 of these commercial providers. And we looked at the characteristics of the patients having these virtual visits and also their outcomes in the subsequent 30 days. Like, did they end up in an emerge or not? And we compared them to all the other types of virtual family physician visits. And the bulk of that was patients seeing their own regular physician virtually. And what we found was that even though these virtual walk-in clinic users were much healthier than the other patients having the other types of visits, they had twice the rate of visiting the emergency department. So this was sort of setting off some alarm bells that, are these virtual walk-in clinics, could they actually be contributing to some utilization? And, this was controversial and, lots of certainly methodological limitations. I'm the first one to say it. We have a follow-up study that is actually in peer review right now that I think addresses a lot of those things. But what I think is this raised in terms of an underlying mechanism is that these virtual walk-in clinics were acting almost like a little bit of a triage function, but at the cost of a physician visit, because these freestanding clinics didn't really have the possibility of seeing patients in person for a physical exam. The physician would make an assessment, is this a condition that they need to be examined or not? And if they need to be examined, then they need to go to the emergency department. And so that's probably what was explaining a lot of the signal. And so I think, people quibble as to whether that is a good use of virtual visits or not, but certainly not the original intended purpose. And I've just kind of transposed the flow of logic here that I had for home visits for physicians to virtual visits, pretty much the same thing. Increased pay was offered by the government to compensate physicians for COVID-19, so loss of income, PPE not being available, risk of infectious disease transmission. That led to a profit opportunity for these high volume providers. And so then they proliferated. And then, of course, these models are focused on revenue. So, see more people quickly, decrease complexity, and decrease comprehensiveness just by virtue of the fact that there wasn't really an option to see people in person. And that these are typically one-offs, totally disconnected from your usual care. So, sometimes a physician that's like 2 provinces away, like they don't know about local resources, so they'll just send you to your local emergency department. So really not what was intended. And this has been mostly addressed by the shakeup in funding that happened in December 2022. So the Ontario Medical Association and the ministry together said, okay, no, now, we're going to really reduce these virtual care fee codes if it's a one-off. If it's an existing relationship, then we're going to keep them at a higher value. But if it's sort of a one-off, no previous relationship between patient and physician, the value is going to drop. Of course, there were people who were unhappy with this, but I think overall it does make some sense. So overall, virtual care is certainly extremely important. It can play a role for patients who are homebound, who have trouble exiting the home. Phone is probably a practical option for many, although you don't have that face-to-face element. So tailored to people's preferences. But the key is that it's within an existing relationship. So a person that exists in real life in your town who could see you in person if needed, and that you have that relationship of trust. So if they say, Bob, like, I think this might help, you actually are going to, there's some weight to that because you have an existing relationship with this doctor. So another example of more integrated form of virtual care is what Renfrew County has developed. It's called the VTAC, Renfrew County Virtual Triage and Assessment Center. Extremely innovative and getting all kinds of attention all over the province. So it was developed in the context of COVID-19, but it continues now. And this is an example of where episodic virtual care can really still be integrated in the system. So the idea is that Renfrew County, pretty much the residents of that area, they see the same group of providers and go to the same hospitals. It's probably just one hospital, to be honest. And so it makes it more feasible to have like a centralized system. They have a single toll-free telephone number. It's a trained medical receptionist that screens the patient. And the publication about this was written in the context of COVID. So at the time, that would be someone you would speak to about your symptoms. They would talk to you about, is it likely that these are COVID symptoms or not? And if they thought that you needed a test, they would actually help coordinate that either through a paramedic coming to your home to test you or an appointment, in a clinic or hospital. And then there was also the option they would coordinate for a physician to assess you virtually if needed. So really coming together via this one central access point. So another example of where virtual care that is integrated can be quite efficient. And in their paper in BMJ Open, they compared the emergency department volumes to other regions. So actually the change, because it was comparison over time and between regions, and Renfrew County's on the left, and these are neighboring other regions. And so they saw bigger declines in emergency department use than surrounding regions. So very interesting, and I know there's ongoing work, and O'Neill may talk about this as well. And I also wanted to put a plug in for 811. So I mentioned that virtual walk-in clinics may have kind of started serving almost a screening function, kind of like telehealth, but with a physician. So this is the rebranded telehealth, Health 811. You dial 811 as a central access point, speak to a nurse, and then you can be referred to a health service. So this is sort of, this was revamped at the same time that the virtual fee codes were reduced to try to remedy the concerns about, we're losing this access point for patients who don't have an attachment to primary care. Now, pivoting a little bit to other ideas, other things that can help keep an increasingly homebound population out of hospital. So you may have heard about home telemonitoring, very sci-fi thing. And there's been a lot more about this in the context of certain disease conditions. So heart failure again, COPD, emphysema. And often what's out there in the literature is very focused on monitoring vital signs. But this is a little bit different. When you think about the reasons that patients like the ones we're talking about come into hospital, often they're having falls. It relates to, mental status. Sometimes there's wandering outside the home. So very future-esque, I think, is these remote monitoring interventions that involve putting motion sensors in different parts of people's homes, sometimes with cameras, sometimes it's just motion sensors, the fridge, the bathroom, the bed, to detect when somebody's fallen, to detect via algorithms when the pattern of movement has changed or there's been no movement. And then typically the person will wear a pendant that they can use for distress calls, and then actually speak to a person, or it can trigger the team to actually reach out to providers that will go and check on them. So either through family or through home care, the equivalent, because these studies are from the United States. So in these small studies, the groups that had these interventions had decreased costs, emergency department visits, and hospitalization. So I think this is sort of a promising area that is still in development. Seems very sci-fi-esque. And so, it's easy to think maybe this is hype, but I think it also does make some common sense, particularly for those patients who otherwise would need someone with them 24 hours. And so this has been, I know even for Ontario, it has been thought of as a potential solution to some of the ALC crisis issues. So patients in hospital waiting for long-term care beds. So finally, and I think it's actually not finally because there's some surprise additions after, but home care. Home care is probably the most important thing that this population needs, and more of it. This is Canada-wide data using the Canadian Community Health Survey, asking the population about whether they have unmet home care needs. And you can see that it's actually 46%-ish have unmet support home care needs. So that means like personal support worker, things like bathing, toileting, cleaning. The home health care services, so things like nurses, physiotherapists, those needs seem to be better at meeting those needs, but we're not meeting people's needs for these personal support work type of home care. And again, in Ontario, we're capped around 21 hours a week, so 3 hours a day. So think about that, right? If somebody is really not able to get to the washroom, bathe, like that's likely not going to be enough. And often when we talk about long-term care, so technically long-term care encompasses both long-term home care and then long-term residential care, i.e. what we call LTC homes, nursing homes, residential long-term care. And we can think about that total envelope of funding of long-term care and look at, how much do we value keeping people in their home versus putting them in a long-term care facility. we can look at the proportion of spending. And actually Canada is really, if you look at the actual spending, we are really tilted towards spending on residential long-term care rather than community-based home care. Other countries are doing a much better job on that front. Now, that's not to say that the long-term care on, like residential long-term care envelope also doesn't need to grow. It also does, and we'll talk about that briefly as well. But if our main goal is keeping people at home, and that's the priority, then probably this ratio needs to be flipped. So what is standing in the way of really giving people the home care they need? So very tight home care budgets, that's for sure. Siloed budgets. So as an inpatient provider, you know, you're trying to discharge your patient home, but you're waiting for home care. Now, does that make any sense when you think about the cost of that inpatient bed versus the cost of the home care? And we'll come back to that in a bit as well. The shortage of personnel. So personal support workers, this is the projected shortage that is expected to grow rapidly over time in the next even 5 years. Low wages, you know, precarious employment in the sense that not full-time, lack of benefits, very difficult working conditions, strenuous work, sometimes dangerous work, right? Going into people's homes. So certainly these are all major limitations, and there needs to be a lot of investment and improvement in the job of being a personal support worker if we're to grow home care. There are ways to kind of improve the efficiency of home care. And this is a plug for what's called the NORCs, the naturally occurring retirement communities. So you may know these by the name like retirement home, or sometimes they're just apartment buildings that tend to attract, like that have a lot of seniors in them. And what's great about that is that people are co-located. So let's leverage that for efficiencies in home care and also for other services that would be beneficial to this group of people. Because, and maybe when I'm saying this, you're thinking, well, you mean this isn't what we're already doing? Unbelievably, it is not. You could have, you know, a building full of seniors and you have like Bob over here who gets home care from X agency, and then like Moira next door gets home care from Y agency, and they're coming from all over the city, and it doesn't make any sense at all. So this is an example of how thinking about the geography and these buildings can really improve the efficiency of home care. Leveraging paramedics also. So area of growth and development in 2021, the ministry announced that they were funding these programs to use paramedics beyond their traditional role of taking people to hospital, assessing them for the need for going to the emergency department, but also for them to provide testing as needed, referrals onto other community services. Sometimes they refer to home care. Another area of development and growth. And finally, sometimes people really do need to go to long-term care. Sometimes I think we spend so much time talking about home first, you know, community, and that's really important. But at the end of the day, there are some patients for whom it's really only going to work out if they end up in a long-term care bed. Otherwise, they just keep coming back to the emergency department. And unfortunately, wait lists for long-term care have nearly doubled in the past decade. It's 40,000 people now. And if you ask the Ontario Long-Term Care Association, they say it's going to grow by 1,000 people per year, up to 48,000 people waiting for a long-term care bed in 2029, which, you know, doesn't make a whole lot of sense. And it's not surprising when you think about what's happened with, you know, the Ontario population over age 75, huge explosive growth, and then completely static long-term care beds. Like, it makes no sense. Wait times for a long-term care bed, this figure makes it look like you don't wait that long if you're in hospital. From my experience, I've had patients who are like on the list, meaning they're on the team, for like 365 days waiting for that long-term care bed. Like, what is the cost of that? Does that make sense? So recently, or I guess I don't know if it's that recent, but there was an announcement that, you know, okay, the government of Ontario is injecting 30,000 more long-term care beds that are going to be available by 2028. So that's great, but it's not nearly enough. So this is a figure from the Financial Accountability Office's review of the spending plan of the government. And you can see that we're really in like the nook of the nadir of the long-term care beds per capita. And it's going to like increase a little bit. We're still going to be lower than we were in 2019. We're really falling dramatically over time. And so we got to do something in this sector too. And finally, sometimes people really do need to come to hospital. So this is another plug for, like going to hospital is not a never event. Some people do really need the emergency department sometimes. And we need to make sure that there are spots for those who need it. On the topic of, hospitalizations are not always a bad thing, I do want to put a plug for alternative outcome measures. So there's been, with all the readmissions literature, it's all focused on 30-day readmissions. It's sort of a binary yes or no. But it really lacks granularity in terms of what is tied to patients' experiences. So increasingly, for example, in the palliative health services literature, there's the use of the outcome days alive at home. And I actually think this is like the best outcome for like all forms of health services research, not just for people who are palliative. Like if you think about what matters to people, it's days alive at home, like being at home, not spending your day in the emerge, not spending your day on the ward. And then the inverse for the people, I guess, the funders, because they want to know about the expensive part. So days in hospital is also could be more useful. Patient satisfaction, looking at functional ability at the time of discharge. Are people sort of able to do their activities of daily living that they need to be able to go home? So I think, if we move towards using some of these measures, then we're able to kind of think about hospital care being useful in the right context. Now, back to sort of hospital care being there when we need it, the share of hospital beds occupied by alternative level of care patients has been climbing. Closer to like 20% presently is my understanding. So that means 20% of our inpatient beds have patients in them who are just like waiting for something. Most of them are waiting for things that they can get quickly, like a rehab bed or home care. But the thing is, even though there's not many of them, the fact that people are waiting a year sometimes for long-term care, those are bed days. That impact is tremendous in terms of limiting the access to beds for other people. Briefly, the history of the policies, the various policy moves in our province to address the alternative level of care situation, from what I could tell from crawling the internet, is that in 2009, we had this standardized alternative level of care definition, which is a patient in an acute care setting who no longer requires the level of services and resources provided. In 2012, we start to see this home first strategy, and that seems to be mostly like a culture change. And the idea is that everyone in hospital should be really focused on getting people home, no matter what, or not no matter what, but like almost no matter what. Hospitals are encouraged to develop these avoidance frameworks. And then there's also like a shifting ethical and legal kind of perspective about consent, risk, this idea of people are, if they're choosing to live at risk at home, that's a valid choice. We shouldn't be pushing people who don't want to go to long-term care to long-term care. Around 2019, 2020, so this is just before COVID, we start to see these reintegration units or transitional care units. And these are essentially, the idea is that you take your ALC population that's occupying hospital beds and you put them in these other places. Essentially, they're wards on buildings that used to be like retirement homes or hospitals that have no longer operate as hospitals. And they go there in a transition period before they go home or to the next facility. And when these things first opened, it was very dramatic. And actually, it worked out well because it was kind of timed with COVID. So we sort of like massive emptying out of all the ALC patients. Like, where did the ALC patients go? They all disappeared. But, as you might expect, like now when I'm on service more recently, people are waiting like more than weeks for an RIU bed now. So did we just kind of shift the people over? Possibly. However, it is true that these units cost less than acute care beds, so there's certainly some savings there. I look forward to seeing more research on the use of these facilities. Right now, there isn't much. In 2022, very recent, More Beds, Better Care Act, known as Bill 7, highly contentious. There's a charter challenge by the Ontario Health Coalition and the Advocacy Centre for the Elderly. Why are they so upset? Because this bill essentially empowers hospital health professionals and administrators to kind of initiate applications for various services and even long-term care facilities without the consent of patient and family members. Now, they can't move you without your consent. So if you If they get a bed and you refuse, then they charge you a fine, or that's at least what they could do according to the law. And my sense is it hasn't actually been used yet by hospitals, but the fact that legally they could it has been concerning to these organizations. So this is sort of the explicit strategies related to ALC, but I want to mention some things that I think actually would be as promising, if not more promising, which is integration of budgets. So I mentioned that, I have these patients, I'm waiting for home care, they're in hospital, but hospital costs a fortune compared to home care. So why is it that the holdup is on the home care side? The way that some places have tackled this. So I found this example from the United Kingdom, where the hospitals or the health authorities charge tariffs, so like I guess fines, to the social service authorities for every delayed discharge, saying like, you failed in your duty to set this up in a timely manner, you shall pay a fee back to us. So I guess that's one option, but potentially more efficient is just if the envelope of funding is shared. So right now, very separate envelopes, home care, hospital budgets. The hospitals have a clear incentive to try to get people what they need so that they don't need to come back to hospital. And yet here we are in a situation where we're waiting for home care. So we're like spending thousands on a hospital bed to like save hundreds on home care. Like it doesn't make sense. So I think what's very promising is initiatives that have sought to pool those budgets. So Kevin Smith was the CEO previously of St. Joseph's Healthcare Hamilton. Now he's my CEO at UHN, and he's brought that integrated care strategy to UHN from St. Joe's. And the plan is also to have a home care agency that's nested within the hospital for this reason, to align those interests. And 12 Ontario health teams have their sort of pilot, or they're set up to pilot this model of being responsible for home care in their regions, in their areas. So that's for 2025. So I really look forward to seeing how that goes. But I think this is the right direction. So in summary, and I have no sense of how I'm going time-wise, but a lot of energy has gone into trying to prevent hospital readmissions, and I would say just admissions in general, and focusing on high user groups with variable success. But there's this large population, and it's growing fast, of older adults with functional impairment where the solutions seem quite apparent. We know what they need, we just don't do it because of presumably the costs is the biggest barrier. So most foundational is really, I think, more home care, getting these folks the home care they need. The physician home visits, virtual care, remote monitoring, paramedics, these are all sort of, they play supportive roles, but I don't think they're going to substitute the foundational need for that personal support care that these patients need in their homes. And integrating hospital budgets with home care, I think, is a great move towards driving some of these efficiencies. And finally, yes, it's an emergency because the demographic wave waits for no one. And I will say, of course, there's many aspects of the healthcare system that I did not touch on today, and they're certainly very important. These are the areas, that I'm most interested in, and I don't mean to neglect these other areas. And I want to thank my research associates, Christine Salahov and Min Lee, my research funders, the various institutions that have housed me or welcomed me, and my various ISIS analysts who worked on this, and all the outstanding collaborators. There's like too many to name, but I do want to give specific shout outs to my mentors and sponsors who are all really brilliant health services researchers. Some of them are internists, some family physician. Andrew Costa is well known to you here, gerontologist, and the others are Chaim Bell, Moira Capral, Noah Ivers, Don Redelmeyer, and Tara Kieran. And with that, I guess I invite O'Neill and his comments. Thank you.
Thank you so much, Dr. Lapointe Shaw. I'd like now to introduce Dr. John Lavis, who is a professor in the Department of Health Research Methods, Evidence, and Impact, who will introduce our discussant, Dr. O'Neill Bhattacharya.
Thanks very much. It's a pleasure to to welcome O'Neill. He was the 2014 Labelle Lecturer, and he's another powerhouse from the University of Toronto. He wears hats at two institutions, Women's College Hospital, where there are 3 hats, the Frigon Blau Chair in Family Medicine Research, the Director of the Institute for Health System Solutions and Virtual Care, and a Senior Scientist at the Women's College Research Institute at the University of Toronto. He's an Associate Professor, if his bio is to be believed, at both IHPME, Institute for Health Policy Management and Evaluation, and the Department of Family Medicine and Community Care. He does pioneering research on the evaluation of digital health tools and virtual care models, also in primary care strengthening. We have called on him many times at the McMaster Health Forum for 3 reasons. He always has the right frameworks to help organize thinking. He always knows how to leverage the existing evidence, and he's really good at speaking in plain language to convey really complex concepts. And the thing that I really love most about O'Neill is he has 3 attributes that are really important for collective impact: judgment, humility, and empathy. He has them in spades. I wish we had more of them. People like him. Over to you, O'Neill. Thank you.
Wow, thanks, John. That's very, very touching. It's really a joy to be back here after 9 years and to share a few words on the other side. So when is this working? Yeah, I think we're just pulling this up. Is this working? Great. So, thinking about when I was invited in 2014, I thought, why are they inviting me? And to now be the person commenting on Lauren's excellent talk, it's really a joy, and it's an honor to be here in this role. So I'm going to comment briefly on some of the general comments she's made, and the subset maybe that relate more to me as a primary care provider. So when you think about when she started in 2011, you said you got into this high users and readmissions area. So at that time, a bunch of us at the University of Toronto, internal medicine and family medicine, received $7 million from the Ministry of Health around the time of the Excellent Care for All Act to study new models of care for people with complex needs. And we'd said, okay, whoever applies has to have a hospital, primary care, and a community services working together. And we had a series of people apply. And one of the models I had at the time was the idea that, we're going to find models that are going to solve this problem, this 1% of patients that generate 33% of costs. And I was really interested in tech and the sort of, startups. And I was like, oh yeah, you're going to find this thing. It's going to be super exciting. And things like the virtual ward tanked. And then there's this kind of trough of disillusionment. You make some modifications, and eventually you find a fit between a program and a public need, and then it scales. So that was the kind of operating model. And I felt like, okay, we're understanding the underlying uncertainty of these models, that most programs in healthcare don't achieve their intended goals. And we did study them and modify and iterate, et cetera. So that was kind of, what we came in with. And, in some ways the model ran for 4 years. We funded 9 models for people with high needs and a range of, different things. 5 of them showed some positive benefit. 2 of them reduced readmissions. 1 of them reduced mortality. 4 of them actually scaled up beyond their initial, sites. And then 4 of them have also been sustained. So in some level, it, was somewhat successful. But the piece, I guess, that, I hadn't thought about at the time is that these are just individual programs, and getting anything to scale. And actually, I didn't give you the, some of the ineffective the models that had negative studies scaled, and some of the ones with positive studies went nowhere. So there's a gap, right? Just because something works in healthcare doesn't mean that it scales. So this takes me to the next area that Lauren touched on. So I recognize that there are good solutions, but they're often point solutions, they're incomplete. But then she talked about virtual care, which is an area of research for me. I've been doing this for a long time. Nobody cared much until, for the early years. And I would present things on this stuff about, I would say back in the day, in healthcare, we are underpowered as a service. Primary care is underpowered because fundamentally we need to manage communication channels. We need to think about the time and the medium of communication. And at its core, virtual care, in a sense, can break the visit. It separates care in space and in time. Now you need to think about that. Okay, is this, how do we schedule these things? Is this incoming from a patient, outgoing from a provider? Are these interactions synchronous, asynchronous, or maybe just open-ended, right? So there's a time dimension. And then there's the medium. Is it text, image, audio, video? Is it in person? Do we get a live feed through, a remote monitoring system? And so I used to talk about this stuff and people would say, oh, that's interesting. Yeah, maybe one day we'll do, whatever. It just seemed like hypothetical. And then in, March 2020, there was a big shift. Unfortunately, people shifted in the simplest way. They transposed the 15-minute visit or the 7-minute visit to a phone instead of it face-to-face. But the idea that we're going to manage communication channels to transform the way care is provided, even 3 years out, we're not quite there yet. But I think it's the beginning of something. So, Lauren touched on some of the downsides of virtual care that, can be very transactional and achieve high volumes of low value interactions. But I think we're just at the beginning of this. And really, we need to think about how do these channels collectively provide comprehensive care, and how can they provide comprehensive care to people with, complex needs. I will say on the telemonitoring, Ontario funded 31 models of telemonitoring, including surgical transitions, some excellent work done here in McMaster on that, COVID, chronic disease, frail elderly. So it is an area that's developing. The other piece that I would say, in the transition of my own thinking, is going from that kind of, incubator for new models of care to thinking a little bit more about systems. Because ultimately we need to understand, how do programs come together? And so this is kind of the next step in my own work. And so I'm an evaluator. I run this group called the Center for Digital Health Evaluation. The Ministry and Ontario Health come to us with all kinds of projects. Tell me how this works. Tell me how that works. And more recently, they've come to us with a range of things that are starting to come together in my head. And so some of these things collectively are things that Lauren talked about. So we've got on the top row, Health 811, right? Which includes health system navigators. It's phone-based. You can locate health services. There's a symptom checker, which, if you play around with it, is pretty basic right now, but the company from New Zealand that runs it is building out something more robust. And then like a library of medical terminology. You can then be referred on to a registered nurse, which is kind of like the old telehealth service by voice, phone, or chat. And now what's being built out just currently is kind of the next step up. So from a registered nurse, you could be referred on to a nurse practitioner. And this is a regional service. And it'll look a little different in the various regions, but it's a nurse practitioner who's available, from a more limited time, but can provide prescriptions again through voice, video, and text. So that's one layer of the first contact, right? The second are more robust services that could be done at an OHT or a district level or county level, like the Renfrew County model that Lauren talked through us. And so just briefly, that model involves patients calling directly to a medical receptionist. In terms of their staffing, they have 11 medical office assistants, 3.5 doctors on site, plus 3.5 doctors off site, and they have a bunch of paramedics as well. There are no nurses in the model, and it really leverages medical office assistants to do to provide those services. And so you've got appointments, virtual appointments with doctors, some in-person kind of hybrid visits, and again, you can be referred on. So think of those as two entry points. The next one is comprehensive primary care. Many of you here have studied this extensively. We know that there are limitations in terms of increasing number of people retiring, fewer people who want to choose family medicine as a profession. And so it's hard to see that growing rapidly. The next area, next entry point in the system is pharmacists. So pharmacy has expanded dramatically very recently, right? We've just a couple of weeks ago, they've added another range of visits. So 400,000 visits in the last year, and probably much more to come. So if you think of these things together, it starts to look at something like the architecture of first contact care. And then below that, you've got the emergency room, you've got the walk-ins. We can throw in Maple and other, virtual walk-in services that now are mostly like employer-based, right? So that's a range of things that are available to us. But what we don't see yet is the kind of comprehensive care that might assist the frail elderly that Lauren has described in a lot of detail. So one model I'm interested in is some of this like concierge medicine for low-income seniors that's coming out of the United States. They're coming out of value-based care models that are fully risk-adjusted, where your cap rate for an elderly person is quite high. So one example is called ChenMed. In ChenMed, physicians have 400 patients on their caseload. Patients are they go to their home to drive the patient to the clinic. They see them with a multidisciplinary team, dispense medication on site with education about this pill does this pill does that, this does this other thing, and they drive them home. And so really it's a recognition that these people need a lot of care. And in a value-based model, I haven't seen, like some of these are run by private companies, they don't share everything, but notionally, you could imagine that high-tech, high-touch primary care for the right people might be a high-value thing to do. It's not an entry point yet, but that's something we hope to see. One of the other things that Lauren talked about was integration and Ontario health teams and the idea of thinking about value. So it is my hope that, as we build out these services, we start to think about, okay, what's the market share of these different things? And if they're supposed to be valuable, then what we need to connect is the back end. Really we want a health system where there's no wrong door. You come in anywhere you like, whatever makes sense to you, but the back end has to be connected. So that means everyone's got access to the same records. Everyone can view the same things. And so that's work in progress. You can see Health Canada making a big push for interoperability. And the case is being made from as a safety argument, not like a tech, harmonization, but as a safety argument. So if we think about how do we bring the back end together, we could start to provide much better value. And the last thing I'll say, Lauren talked about being an internist, stuck in on the ward with all these patients who can't go home when all they need is a PSW support or something. If an OHT managed a budget and they were accountable to a population and to the value of care, and maybe with a US style downside and upside risk, if predicted costs come in or actual costs come in under predicted, they might start to think about what they fund. And they might maybe look at PSW and home care support differently than they currently look at fourth-line chemotherapy for cancer. And maybe we need to start thinking about these things together, because they're the foundation of the system that we want to build. And that really, if we're trying to move towards value, yes, we've got Canada Health Transfer with lots of new dollars, and some of it's going to go into primary care, but it's always going to be constrained. And if we can't think at a regional level, how do we balance things of differing value that are currently completely separate? I don't see how we're going to get there. Frederica Scarth, when she started working on, it was the Committee to End Hallway Medicine and really pushed this idea of Ontario health teams, she said, I think it's a decade away before we get close to where, ACOs are. I don't know, that was 5 years ago. We're not quite there yet. But I do think we're going in the right direction, and I'm optimistic about many of the things that Lauren talked about. But how do we get to a point where a home care provider, which is a very very small group with not a lot of clout, can attract resources from the hospital sector, and how within an OHT would these things balance out? So I leave that with you, Lauren, for your comments.
Thanks very much, O'Neill. And of course, I had the joy of driving down with O'Neill, so we may have had a sneak preview to some of these ideas. It was a very lively discussion. And I think, you touched on some very interesting points related to programs in isolation and what is their potential to really make a difference to the population of Ontarians. I think it's encouraging that, some of these models are being scaled. Certainly trying lots of different things seems like the way to go to be able to land on something that's effective. I think I come back to my original point, though, that for some groups, it's quite clear what's needed, and yet we still don't, provide that to them, and that's specifically home care. And I think just maybe jumping to the end of what you were saying related to, what is needed to get to a place where we think about funding of home care differently, and, think about it the same way we might think about access to chemotherapy. And I think what came to mind for me, and some of you, because I know this is a health economist crowd may be familiar with this, but that in the UK, the NHS has been transparent about the average cost effectiveness of the NHS as a whole in terms of the cost to qualities that NHS care buys. And then, when there's a question about a new intervention or a new service, they don't use this ICER of incremental cost effectiveness of $50,000 per quality as the threshold. They instead, the question is, how does the average cost per quality of this intervention compare to the overall cost per quality of the NHS? Because the money's got to come from somewhere. And so, as we move further into the world of precision medicine and, molecular targeting, these things certainly cost a lot. And I think in the spirit of Roberta Labelle and being provocative, I think we need to think about what we're foregoing in exchange for that, and how many more people could get, the home care that they need. And I think related point is also that, we're going to pay for it either way. Like, even if we choose not to fund the home care, we're still going to pay for it because the emerge is open. And so it will actually lead to admissions. And so it's either, be proactive or be reactive from my perspective. I really liked this idea about the concierge model for low-income seniors, because this is the population that really needs the concierge care. And I think we shared the question as to whether or not it's actually cost effective, and maybe it'll turn out like Uber, where they were actually losing money over time and no one knew. But I think this is something that I'm going to look into further, because I think it sounds promising. I agree with you. The systems integration piece and having a shared envelope, I really do think, again, having that connection hospital to home care is key, because if we pair up the most expensive service providers with sort of the least expensive, in the sense that that's where we're spending the least money, then we can really think efficiently again. So we're not spending all this money on in-hospital care just so we can save hundreds of dollars on home care. So I think I know this is supposed to be a critique, and I was a little bit shaking in my boots, but I think mostly we are in agreement on a lot of these themes. Thank you.
Thank you so much. I would now like to open up our question and answer period. And I think Dr. Lapointe Shaw and Dr. Bhattacharya can sort of moderate that.
Oh.
Yeah.
Okay.
For context, it feels like this is the same as game changer. OHTs with an attributed population, and they're accountable for a pretty simple program metrics. They can start to make these much more strategic decisions that O'Neill was saying. And then throughout your talk, Lauren, I kept thinking, but some of this stuff, Andrew Bond's shown that he can do in a much more integrated, concierge-oriented way for homeless and precariously housed people. And then O'Neill introduced the US variant for low-income seniors. I wondered if either of you have any reactions to, and we also learn from some closer to home models like what Andrew does, and think about applying them to this population. If you look closely, is there good evaluation data coming out from it? Where are we with that experience?
I will say that I'm not, so the question, I should repeat the question. The question was, what can we learn from integrated models that exist, on our side of the US-Canada border, and in particular, the work of Andrew bond, looking at homeless populations and creating some of this concierge type medicine, wraparound care for this population. And I will admit that I'm not familiar with that work myself, and so maybe O'Neill is, but I think certainly there's many parallels to be drawn there. And I guess it comes down to, having motivated individuals, but also freeing up the pockets of money. And it may be that the homeless population, in some ways, I would say it's smaller, right? Like the count of people is smaller, and then oftentimes they're also somewhat co-located in the sense that it's certain regions in a city. So there's maybe it's easier to be a little bit more nimble in creating services for this population. Whereas when you think about all the seniors sort of in their homes all over the place, you need a bigger scale operation potentially. But I agree, in principle, and I don't know if you're more familiar than I am.
We'll have to chat about that afterwards, John. The one thing I'll say from, what I've seen in work on homelessness is the idea of peer navigators. And we're seeing more of that at my hospital, Women's College. We're doing it with people with substance use issues as well as refugees. And the idea that you need to build trust and engage people with people who are more like them. So whether you would have like a senior peer navigator is an interesting question, but there are certain populations I think that, we've underinvested in that. How do we build trust in relationships?
Thank you very much for either of you. The discussion starts with we have resource shop, better resources, the written model, and very kind of downward. What I didn't hear is we're taking it from a different perspective, that it's actually patients. And I would think that there's like 3 levels of patient needs. You have people who are at home, perhaps homebound, but they're going to get sick. So they have exacerbation of COPD. How are you going to do that? So this is like a stable person who's no longer stable. And then the other patient is the patient who's kind of in hospital, had heart failure, to send them home, but they still need ongoing monitoring, not as much as in the hospital, but more than stable. And then there's the patient who's at home who maybe is very stable, but want to make it shame they don't get dehydrated, their nutrition so that they don't deteriorate. Those are 3 different kinds of population of patients. And it sounds like the models aren't really thinking that way. They're thinking, well, we have resources. How are we going to keep those people from ending up back in hospital, as opposed to thinking it from the patient perspective of those 3 folks?
I think it's a great point, and certainly, it makes total sense. So I have to repeat the question, sorry. So repeating the question was, our presentation, or my presentation, was focused sort of on, these are the systems we have and how can we better utilize the resources, as opposed to taking a lens that is centered on what the patient needs, in particular different phenotypes, I'll call them, different types of patients and different needs. And I completely agree. I guess, I think the tricky thing with the lens totally focused on patient needs is that, first of all, who's assessing the needs? Like patient perspective, certainly very important. I will say that I think the realities of our healthcare system sadly fall very short of, I think, what any given patient would probably want as their ideal state. So I will say that I think thinking about the phenotypes is a great point, and that sort of speaks to the need for mapping the journeys of these different types of patients, and thinking about the different types of risk. At the end of the day, though, because the resources are so limited, I think it's hard to escape the focus on how do we conserve this very pricey resource. And so who are the people that are actually utilizing that, and how can we help them the most? And unfortunately, it's like there's many patients with a lot of needs, and at some point the decisions do tie into, what will happen if we don't help them, right? And so if it's a population that will use the most expensive form of care, then I think it makes sense to kind of put dollars in that direction. But I think that is certainly up for debate too.
I'll add, I threw this up based on being asked by Ontario Health to evaluate different things that were created independently. And we're like, okay, how does this stuff fit together? But clearly you could remap this through what you just described. Here's 4 different personas, archetypes that have a different set of needs. In fact, that's kind of the next phase of work here, because we want to be able to show that these are the gaps that remain. So I think Lauren's right that there's, there are resource limitations, but you're absolutely right. We need to build from the patient perspective, at least to create something that's rational.
And as a parent who once had patients at home, I wondered about what happens. So once we had these patients called, and every time we called Ontario Health, it was taken to the emerge. And so I'm curious about, sometimes I wondered if that was because of the medical aspect. Sometimes they didn't want the responsibility of getting it wrong. They would see the child and they don't get enough information. And I don't know if anybody's taken a look at the medical legal aspects of all of this, particularly self-triage and assessment, virtual assessments. Are we seeing uptick since there's so many more? We're seeing an uptick in medical legal aspects of error, negligence, malpractice suits, any complaints, things along those lines. And do you think that would be a place to look for measurements of success in some of these?
On the harm side, I did a systematic review of virtual care and primary care. It kind of ran halfway through COVID. We didn't see studies that demonstrated harm. And then after that, CADETH did another one, and they pulled a few things. They didn't summarize the harm, but it's actually relatively few studies showing systematic harm. I think there's a lot of anecdotal harm. And for sure, like imagine in April 2020, there was like the proportion was totally off, right? So the question is, in a steady state, how much harm is there from these models? I don't think we know, but we've shifted a little bit forward on that.
I'm reflecting a little bit on, well, first your comments about kids with colds and home visits. And I did want to just throw in, because you said, as somebody who had children at home and I've had some good dialogue with colleagues who kind of say, well, what's to say that's inappropriate? Like, what if, working parents, single parent, kid at home, that's the only way they can access care. And, I think that's a very valid point as well. It does speak again to this, how do we prioritize like what, where the dollars should be spent. The medical legal point is fascinating to me. And I do think, by virtue of being right next to the United States, there's like contamination, like we're increasingly legalized. And I wonder in Europe, if there's more comfort with providing that self-care advice and not saying, go to Emerge. And we actually just had that exact conversation in the car. I said, so I don't know if it's still how it used to be, but when I was a resident, telehealth just told everyone to go to Emerge. Is it still like that? So it's the same sort of covering the legal basis. Ideally, you would be talking to someone who's semi-familiar with you, who kind of knows your threshold of worry and says, this is something you could manage at home. But realistically, that's hard to achieve, right? You can't have your own doctor on call all the time. So I don't know how we get there, in terms of having more comfort with self-care. Certainly a more health literate population helps, like people are able to just Google for better or for worse. And then sometimes for better, which is good. Sometimes for worse. I'm sort of realizing I lost the thread a little bit, but I think I've mostly answered your question.
Yeah.
Great point about what about the caregivers? And I did not really delve into the world of the informal caregivers, which is in fact propping up the whole health system presently to their own great detriment. And, there's lots of literature, of course, as that caregivers suffer as a result of their caregiving, they have adverse health outcomes themselves. They can withdraw from the workforce, which has costs from a societal perspective. 100% this should be accounted for. And I think actually that makes me think of other tools in the form of like better tax preferences, tax treatment credits for the work of caregiving to actually put more money in the pockets of these folks who are doing really the work that our healthcare system is not, or our social support system is not. Ideally, you know, they wouldn't be put in the difficult situation of feeling like if they don't provide that care, that no one will. So that's really a heart-wrenching position to be in, 100%. We need to study their outcomes, and I think they are in a good position to help actually advise on solutions.
It's one that briefly comes to mind. I, critique the idea that any program is going to solve this, but I still get excited about certain programs. There's a Dutch program called Care Chain Frail Elderly, where they do these assessments in the home of the capacity, the goals and capacity of the patient and the caregiver, and reassess at multiple time points to ensure that their capacity is increasing and they're advancing in their goals. So to make that an explicit target, I think is very wise.
Yeah, thanks for the question. So I think the question was that I mentioned home care reduces continuity, but I think in fact it's physician home visits, and it's the slides with the results from the physician home visits study. So what we found that a large number of these physician home visits were to patients who had what seemed to be low needs. I mean, you can't really know for sure, but based on the markers we had in the data. And then also they were typically with outside physicians. And so the concern was that, and I didn't speak to it, and perhaps I should have, but it's on the infographic. It introduces another care provider into the mix when patients already had a primary care physician. So there's this discontinuity as a result of that, as opposed to a model where it's your own physician who can provide a home visit to the patients who really need them, like who can't get to them otherwise.
Sorry, so the home care is not provided by the registered physician?
Right, so home care, right, so this is an important distinction. So home care is like delivered by the home care providers, so that's like personal support workers, nurses, it's not physicians. And then there's a separate thing called like physician home visits. And it's perhaps surprising that they are disconnected things, but they're two totally separate things actually. Yeah, but it would be better if they weren't.
Yeah, so I have a question. So like the recent reform, like family health team or Ontario health team, they use like electronic medical record. Is that any helpful to reduce that help improve the continuity? Yes,
so definitely the Ontario health team has the promise of having continuity between these groups. The key thing is having compatibility of information systems, as O'Neill I think touched on, and I think you also mentioned like family health teams in there. The family health teams as it stands now are not integrated with the home care providers, but under an OHT model the idea is that they would be. Yes.
Thank you.
So the question is whether penalties for providers. Right, and okay, so the question is whether penalties might optimize the care transitions. And then this may be related to the point that I made about how in the United Kingdom, there's a penalty if the home care services aren't set up. I think, having some financial incentives in place in whatever form could be helpful. I think probably it's most efficient though to use a carrot rather than a stick, which is sort of the penalty, and the carrot being really integration, having the shared budget and the flexibility to move the funds around to where they're likely to be most useful.
There's no more questions.
Thank you both very much. I do have a couple of announcements just before we get going. So the first is that Dr. Lapointe Shaw will be available for meetings tomorrow morning, and there's still space available to join her for lunch tomorrow. So please let us know if you're interested in that. The second is that I'd like to draw your attention to a new scholarship created by CHEPA founding members, Doctors David Feeney and George Torrance. The scholarship will support doctoral students, and there's opportunity for you to contribute so that we might expand the scholarship. And lastly, this lecture is followed by a reception in the Farncombe atrium. So we hope to see you all there. Okay. Thank you again very much, Dr. Lapointe Shaw and Dr. Bhattacharya, and thank you all for joining us this afternoon.